Hi everyone, this is Professor Rivera-Mitu, and today we will be talking about hypervolemia or fluid volume excess. So I'm going to present on hypervolemia and all of its signs and symptoms. So I'm starting with possible causes of hypervolemia. First of all, let's define hypervolemia. It is an excessive amount of fluid um, in the blood vessel. So when we're thinking of different conditions that might cause an excessive amount of fluid in the blood vessels, what I've done is I've kind of divided it between the main systems that may contribute to an increase in volume in the blood. So starting with heart conditions that may cause hypervolemia, one of the common cause is, let's start with a chronic lung disease. So if a person has chronic lung disease, that means that there is a problem with gas exchange, and that increase in the gas exchange, that decrease in the gas exchange, along with congestion in the alveoli due to a lot of secretions in the alveoli, could lead to pulmonary hypertension. So pulmonary hypertension is an increase in pressure in the pulmonary arteries. And if you recall, the pulmonary arteries, it's the part of the circulatory system that gives the deoxygenated blood to the lungs, right? So this is forward flow to the lungs coming from the right ventricle. So then if there's pulmonary hypertension, which is again high pressure in the pulmonary arteries, then that backs up to the right ventricle, and enlargement of the right ventricle or right ventricular hypertrophy is called cor pulmonale. So cor pulmonale is a direct effect of chronic lung disease. So now that there's backup into the right ventricle, with enlargement of this, then that can cause weakness of the right ventricle, which could lead to backup to the right atrium, and backup of blood to the superior vena cava and inferior vena cava. And I'll come back to this when we talk about the left side heart failure. So it's either that it begins from a chronic lung disease, a chronic lung condition that leads to weakness of the right side, or it could be from a left side heart failure. And there's, many conditions that could lead to left side heart failure. That's something that is covered in a fourth semester. But let's just start with a patient having left side heart failure. And in that situation, the left ventricle is too weak to provide forward flow of blood. So what happens with the blood, instead of being pumped out through the aorta, is it stays in the left ventricle because of its weakness. And so then it backs up to the lungs. And then from back up to the lungs, the same thing happens. It backs up to the right ventricle, to the right atrium, and again to the superior vena cava, which is the upper part of the vena cava, and then that can lead to congestion that leads to angioedema. So venous congestion that leads to edema in the face, that's angioedema. And it leads to venous congestion in the lower extremities as well as in the thoracic abdominal area. So when there's venous congestion in these areas, there's third spacing. So third spacing happens when there's such a great amount of pressure in the blood vessels that the blood doesn't know where else to go. So then it shifts outside of the intravascular space into the interstitial space or into the cavities. So when it shifts into the interstitial space, and by definition, that's what edema is. So wherever there's interstitials, areas wherein fluid shifts to, there will be edema. And so because of gravity, this is commonly something that is seen in the lower extremities, and then that could begin to rise up. So when we're measuring edema, not only are we measuring how deep this edema is it pitting, is it non-pitting, but also how high does it go up? So does it start just in the foot, or does it go up to the ankles? Does it go to mid-shin, below the knees, above the knees, thighs, and as it goes up, it could go into the scrotal area, the sacral area. If someone is bedridden, there will be edema there. And eventually could lead to anasarca. So anasarca is generalized edema of the whole body. In the visceral cavities, it could lead to effusion. So effusion is fluid in the cavities, such as in the pericardial cavity, which is what covers the heart, or in the pleural cavity. So there could be pleural effusion, or there could be pericardial effusion, fluid collection in those pleural cavity. This effusion could also lead to third spacing in the peritoneum, and that's ascites. So that's that third spacing into the peritoneal cavity that could lead to ascites or fluid collection in the peritoneal cavity. And that kind of leads us to conditions that affect the hepatic system. So when someone has liver cirrhosis, and liver cirrhosis could be from a chronic hepatitis, such as hepatitis B or C, or it could be from alcoholic hepatitis. It could be from fatty liver disease, which is also known as non-alcoholic steatohepatitis. Steato meaning it's caused by fat. All of those first leading to liver fibrosis, which can become liver cirrhosis. So in liver cirrhosis, there's scarring and hardening of the liver tissues. And so when there's hardening of the liver tissues, there's a blockage in the circulation into the liver. And so with that, the main vein that collects blood from the liver and goes through the liver, the portal vein is also the vein that goes, that is alongside the GI mucosa. So this runs along the GI mucosa anywhere from the esophagus down to the anus. And so when there's portal vein hypertension, again, that leads to venous congestion, which brings us back to the third spacing and the edema down here. And again, the ascites that happens from third spacing into the peritoneum. Liver cirrhosis can cause hepatocellular carcinoma, or there could be other causes of hepatocellular carcinoma. But basically, when the patient has either one of these, that can cause portal vein hypertension. And we know that albumin is a product of the liver. So it comes from the liver, it's produced in the liver. And so when there's malfunction of the liver, such as in liver cirrhosis, then there's also malfunction in the production of albumin. And so that causes hypoalbuminemia. And when someone has hypoalbuminemia, not only is there a problem with wound healing, and they're actually prone to wounds because of the lack of albumin, which is a protein, but we also have to remember that albumin is responsible for oncotic pressure. So oncotic pressure is that pull of fluid back into the blood vessel. So albumin is responsible for making sure that there is a normal pressure within the blood vessel by pulling fluid back into the intravascular space. So if there is no albumin, there's nothing that pulls or keeps the fluid into intravascular space, and so therefore the fluid shifts. And again, it's going to shift from the intravascular, from inside the blood vessel into the interstitial space. And that is what causes edema. So there's also edema in that type of issues in the hepatic system. Or it could be a renal problem. So there's different renal issues. And again, this is fourth semester content, so I'm not going to explain this as much, but I do have some videos that may pertain to these. But basically, there could be a decrease in perfusion to the kidneys that can be caused by a pre-renal. So when we say pre-renal, it's something that is happening to the blood vessels that provides perfusion to the kidneys. So some examples of that is uncontrolled hyperglycemia and diabetes, which could also lead to hypertension. It could be sickle cell disease. It could be SLE, systemic lupus erythematosus. So anything that causes decreased blood flow to the kidneys will cause kidney damage, will cause the kidneys to fail. And so over time in a chronic condition, with these chronic conditions here, that can lead to chronic kidney disease. And the late stage, the end stage of chronic kidney disease is end stage renal disease. So how we determine how low the functioning is of the kidney, aside from GFR or the estimated glomerular filtration rate, we also look at these lab values. So we'll look at the serum creatinine and see how high that is. Is it greater than 1, 0. Usually it's 0.8 to 1.2. Depending on the facility, could be a little bit lesser than that. Or along with that, is there an increase in potassium? And this again tells us how much malfunction there is in the kidneys, depending on how much it's retaining the potassium, it's not able to excrete it out. Or a decrease in urinary output. And again, we normally look at, especially in acute kidney injury, we'll look at the kidney output of less than 30 mLs per hour for at least 2 consecutive hours. So in AKI, which is acute kidney injury, so this is something that happens acutely. In this case here, it may be reversible still, as opposed to CKD, ESRD are non-reversible because this happened over time. With AKI, it could be an intrarenal or post-renal condition that had caused kidney damage. Intrarenal is something that had happened to the kidneys themselves. For example, nephrotoxic drugs, such as vancomycin, anti-tubercular medications, in CKD, chronic use of NSAIDs or aspirin or COX-2 inhibitors, which are also NSAIDs. Post-renal has to do with a condition that began after the kidneys, which are the ureters, the bladder, the urethra. So if there's any blockage, for example, in BPH that had caused retention of urine or cystitis, especially in females from UTI, that had caused pyelonephritis, that eventually causes kidney damage. So all of those conditions can lead to AKI. And then again, AKI or ESRD can cause fluid retention because the kidney is not able to excrete the fluid. And so that could cause hypervolemia. With these endocrine issues, most of them go back to the kidneys, but I want to point out that this, they're hormonal, something to do with the hormones that's controlled by the endocrine system. So let's start here with the adrenal cortex, which is controlled by the anterior pituitary gland. So if there's a problem with the adrenal cortex that causes hyperaldosteronism or the excessive production of aldosterone, and we know that aldosterone affects the kidneys, And what it does to the kidneys whenever aldosterone is involved is twofold. One, it causes reabsorption of sodium chloride in water, and that is what would lead to fluid retention. But at the same time, whenever there's hyperaldosteronism, we want to also look at the potassium because it excretes potassium. And in an excessive amount of aldosterone, there might be an excessive loss of potassium that could lead to hypokalemia. And so we would want to watch for that as well. In pregnancy, we know that the placenta is the main organ that will secrete hormones. And so one of the hormones that it secretes a lot of is estrogen. And estrogen is responsible for increasing the vascularity, which means not only is there an increase in blood volume, but there's also production of new blood vessels during pregnancy. And so with increased vascularity and increased cardiac output, then that leads to more volume, again, that causes fluid retention. And in another condition caused by the posterior pituitary gland, wherein there's an excessive production of ADH. ADH is anti-diuretic hormone. This is also known as vasopressin. So this condition is called SIAD, or syndrome of inappropriate anti-diuretic hormone. So in this condition, there's an excessive amount of ADH, and so ADH tells the kidneys to reabsorb water only. And it's important to note that if it's ADH that is causing this, there is no reabsorption of electrolytes, it's only reabsorption of water. And as a consequence of that, the blood becomes diluted. And so there is no increase in the RBCs, no increase in the hemoglobin, no increase in the electrolytes. So because there is a lot more of the fluid, they all look like they're diluted. And so we might see a dilutional anemia, dilutional hyponatremia. So it's going to look like the electrolytes are decreased and that the blood components are decreased, but it's just that they're floating a lot more fluids because of the reabsorption of water. And then again, of course, that causes fluid retention. There's also a condition called hepatorenal syndrome. So hepatorenal syndrome is really just a collection of the symptoms from a person with hepatic disease and renal disease at the same time. This could even be the same person who also may have left-sided heart failure. So if they have like all of these issues, it's possible for them to have a hepatorenal disease and will have the same presentation. So apart from these signs and symptoms that we have already identified here in red, let's look at other issues that may happen to this patient. So if there's an increase in blood volume, of course, there's an increase in cardiac output. And when there's an increase in the cardiac output, we know that that's going to increase the workload of the heart. And so if this is something that is chronically going on because of end-stage renal disease or because of liver cirrhosis, then that excess amount of fluid can lead to left-sided heart failure because of the increased workload of the heart if the patient doesn't already have left-side heart failure. And so it's kind of like a vicious cycle that's going to just continue to increase the fluid. In addition to that, now we're looking at arterial blood vessels that is full of fluid, right? Because this is hypervolemia. When we say there's increased cardiac output, we're looking at the arterial system, not just the venous system. And so if there's a lot of fluid, then that could cause an excessive amount of fluid that is shifted into the cells. And so that's going to cause intracellular edema, apart from the interstitial edema that we talked about here. So this is now inside the cells. And so we want to look again at the main organs. And so if there's edema in the brain, that's going to cause cerebral edema. And that can cause an altered level of consciousness, anywhere from lethargy all the way down to coma. And of course, there will be decreased brain function as well. And so we would want to watch the functioning of the medulla oblongata and see if there's alteration in the vital signs because of this issue. In the lungs, it's going to cause alveolar congestion, meaning the blood, the fluid is going to shift to inside the alveoli. And when it shifts to inside the alveoli, then we know that the oxygen is going to have a hard time going through from it being ventilated, being inhaled into the respiratory system and exchanged in the alveoli. And so because of the decrease in the O2, then that's going to cause hypoxia. And how do we know that this patient has hypoxia apart from measuring SpO2 or ABGs? There will be increased respiratory rate. There will be a subjective complaint of dyspnea. And arguably, there will be an increase in heart rate as well, tachycardia, because of the increased work of the pulmonary system. As blood is shifted into the alveoli, then we're going to hear rales, which is coarse crackles. So it's kind of like that bubbling in the alveoli as the patient inhales and exhales. And if the patient has a cough, or this could very well trigger a cough because it's foreign in the alveoli, then they might have pink frothy sputum, which tells us, again, there's blood or excessive fluid in the alveoli. In the kidneys, because this is intracellular edema, it could cause kidney hyperplasia. And in the liver, it could cause hepatomegaly. So again, chronically speaking, these conditions could, again, lead to liver malfunction for the hepatomegaly or kidney malfunction in hyperplasia. So I will continue this map by looking at interventions, but as far as the physiology and pathophysiology, we will end it here. So now let's talk about the interventions for hypervolemia based on the different causes of hypervolemia, starting from cardiopulmonary. So if the cause is pulmonary congestion, these are not really interventions for hypervolemia, but I wanted to add them on here to prevent right side heart failure from happening, and so therefore preventing venous congestion. It's just to treat that chronic lung disease. So common treatment would be a steroid, beta adrenergic agonist, such as a short-acting beta agonist, which is a rescue medication, or a long-acting beta agonist, anticholinergics or muscarinic antagonists. So those are for lung disease. For left-sided heart failure, there's a lot of medications, but typically an inotropic drug, which is going to increase the contractility of the heart. And by increasing the contractility, then you're preventing a backup to the lungs. Beta blocker, which will decrease the heart rate and therefore increase the ventricular filling, basically giving the ventricle more time to get filled with deoxygenated blood. That way it can pump it up, pump it through the left ventricle to the circulation. Anytime there is venous congestion or congestion in the blood vessels, a loop diuretic is a go-to medication that will basically prevent reabsorption of that fluid in the kidneys and excreting it out through diuresis. Keep in mind that if we are giving a loop diuretic, the electrolyte that we want to watch out the most is potassium, because there could be a complication or a adverse reaction of hypokalemia when using a loop diuretic. If the problem is due to decreased albumin, whether or not there's presence of liver cirrhosis, then of course, we just have to replace the albumin. And then when albumin is replaced, the oncotic pressure will return to normal, and that will prevent the shifting of the blood from the intravascular space to the interstitial space. For liver cirrhosis, there's really not much to do there, except really just preventing the progression of liver cirrhosis. And once it's there, we're just basically treating the effects of it again, which is the venous congestion, needing a loop diuretic for any edema. If there is ascites, then this patient is going to have a paracentesis, typically on a regular basis, like maybe every month, every 2 months, depending on how much fluid is shifting into the peritoneal cavity. In the presence of renal disease, even if it's an acute kidney injury, but there is these signs, there's increased creatinine, there's increased potassium, or decreased urinary output, then they might go in a temporary dialysis as well. And an ESRD, which is permanent in end-stage renal disease, and again, this is a GFR of 15 mLs per minute or less, then this patient's gonna need regular hemodialysis or peritoneal dialysis for the rest of their lives until either a new kidney is found and they can have a renal transplant, or unfortunately they pass away. Now I want to point out this increase in potassium here, because these are the different interventions that will be needed when there's hyperkalemia. There's two main mechanisms of action that we're targeting when there's an increase in potassium. Number one is we want to increase the excretion, right, of potassium. We want to get it out of the blood. And two, we want to shift it back to the cell where it belongs, because potassium is the main intracellular electrolyte. So in order for us to get it out of the system, of the blood, there's two routes, GI or GU. In the GI system, we're using kayexalate. So kayexalate is a potassium binding laxative. And so what it's going to do is bind the potassium in the gut and then excrete it out through the GI system. So the patient's going to poop out potassium. And they're going to have diarrhea because, again, it is a laxative. And with that increased amount of potassium, that's just going to cause softer stool. And in the GU system, again, Lasix, because it causes hypokalemia, would be, again, the drug of choice as far as diuretics are concerned. So that's going to bind the potassium in the nephron, in the loop, and then excrete it out through diuresis. In shifting the potassium back to the cell, there's two ways that we can do that. One is by administering albuterol, which is a beta agonist. So one of the actions of beta adrenergic agonist is the shift of potassium from the intravascular to the intracellular area where it belongs. So they might give albuterol. And also administer regular insulin. So this is the only insulin that can be administered IV, and in this case, we do need it IV. And however, because insulin opens the insulin receptor in the cell to take in the potassium back, then it's also going to take in glucose and calcium back into the intracellular cavities. And in order for us to prevent the adverse reactions from that, we are giving D50 to prevent hypoglycemia, and we are giving calcium gluconate to prevent hypocalcemia, because again, once that insulin receptor is open to receive back the potassium, then it's also going to receive back glucose and calcium. So we want to make sure that the patient has enough reserve of that so as not to have the adverse effect. In the condition of SIAD, syndrome of inappropriate antidiuretic hormone, Again, we will be addressing the excessive fluid, excessive water. And so there's two things. Again, loop diuretic to release some of that fluid outside of the body through the kidneys. And then also, they likely will have a short-term hypertonic IV. So keep in mind that hypertonic is an increased concentration of solutes in an IV. So for example, an isotonic solution is 0.9% sodium chloride. So if we're giving a hypertonic solution, so that percentage of the sodium will increase. So that could be a 3% sodium chloride instead of a 0.9% sodium chloride. It's important to note that these types of treatment are not long-term, because if they give it long-term, then it's going to do the reverse, which would cause cellular dehydration. And so we don't want that either. In the adrenal cortex, in the case of an hyperaldosteronism condition, we know that a potassium-sparing diuretic such as spironolactone, the main class of it is as an aldosterone inhibitor. So it inhibits aldosterone, and so which is really what we want here, because we want to counter the abnormality of the increase in the aldosterone. So we give an aldosterone inhibitor, which is a potassium-sparing diuretic. And of course, that will reverse the effect here. And so there will be a decreased reabsorption of sodium chloride in water and a decreased excretion of the potassium. So that basically solves both of those issues. And in the case of the effusions into the cavities, if there is pericardial effusion, then the patient is going to have a pericardiocentesis. If it's a pleural effusion, the patient can have a thoracentesis. Believe I put, oh yeah, I already talked about paracentesis in a case of ascites. And in the case of cerebral edema, again, this is something that is not long-term, might be a 1 or 2 doses of an osmotic diuretic, which is mannitol. And that's for cerebral edema. So another treatment would be the same as Insiad, which is the hypertonic solution, again, something short-term. With an osmotic diuretic, which is also a hypertonic solution, what it's going to do is basically pull the fluid from the cell into the blood vessel, into the intravascular space, and again, excrete it out through diuresis. And, in lung issues, then of course, we know that we're going to give oxygen. To this patient, we can give steroids to decrease any inflammation that is contributing to alveolar congestion. But again, those are not interventions directly for hypervolemia, but just for the signs and symptoms of hypervolemia. And that's about it. If you have any questions, feel free to reach out.